So my name is Mika, and I am the head of the Occupational Environmental Health Division here in the school. And it's my pleasure to welcome you to the regular Occupational Environmental Health Seminar Series. This is one of a series of environmental health seminars by candidates for our new assistant professor position in environmental health in the school. It's my pleasure to welcome today Dr. Jana Hirsch, who is a assistant research professor at the Dornsife Public School of Public Health at Drexel University in Philadelphia. And specifically in that school, she's with the Urban Health Collective. So Dr. Hirsch is an interdisciplinary researcher whose work aims to understand the way neighborhoods shape health behavior and disparities. She has primarily worked at the intersections of urban planning, geography, and population health, with a focus on built environments and physical activity among adults and older adults. In particular, she has examined the way walkable communities can increase walking for transportation or reduce normal declines in mobility with age. Her current work includes longitudinal examinations of the way in which neighborhoods change and the subsequent impact that these changes have on health and population health. Personally, and I know this, having spent the last day and a bit with her, she's an eager and active walker. She's probably walked among almost all corners of the campus since she's been here, and is a people-focused urbophile. Urbanophile?
I don't know, different people use
Say different
it's a made-up word, it's okay.
So Dr. Hirsch is going to share a little bit about the research that she has done, the research that she would like to do as part of an assistant professor position in the school. So we welcome you. Thank you very much for joining us, and the floor is all yours.
Great.
Thanks.
Thank you so much, Mika. So, good afternoon. Thank you all for joining me, whether you are required to or not. I am going to go through a little bit about constructing evidence for built environment's influence on health and equity. In case you are one of those people who wants to count down the time, along the bottom will be the section that we are on, and so you'll know if we're getting close to the end and you need to duck out. So first I will talk to you a little bit about the history and setting of these fields coming together, my past work, my present work, and then the future work that I think is important for the field that I have started to embark on. And I do apologize that I'm a little bit tied to the podium. So I don't have a clicker. So and how many of you, is anyone here an urban planner? No. Is anyone here a historian? No. Does anyone here know the history of urban planning and public health together? Great. Yes, one. Good. Well, you don't have to listen for the next little bit, and everybody else can pay attention. So urban planning and public health actually started out as very close fields and kind of grew out of the same space. So before World War I, all across what we would now call the developed nations, but especially North America and in Canada, there were huge amounts of population growth, and a lot of that was in cities. So we saw between 1871 and 1911, you see here that Canada went from 3.7 million to 7.2 million people. I know still not a lot of people, but quite a growth. And you ended up with 4 cities that had over 100,000 people. And these changes led to a whole host of housing, social, and environmental issues, specifically around infectious diseases, housing conditions, and then toxic industries that were close to residencies. And so in around 1911, we had a really low life expectancy. These are the numbers for Canada. Here are some images from a number of the slums in Toronto and Montreal. I believe this one is Montreal. These two, this one is Toronto. This one's Toronto, and one of them is also Hamilton, I believe. And so there's this book, Unsanitary Housing. If you are really into history and into environmental history, I encourage you to take a look at it. It's open source on Google, and you can read about some of the plight in cities at this time. And so urban planning was kind of seen, and at that point it was called town planning, as a public health response to a lot of these issues. So here's a statement from Unsanitary Housing, where Charles Hodgetts specifically says that he would say no government can justify its existence, which is a pretty strong statement unless it carefully considers this important question, which he's talking about housing and environments and urban structures, and creates laws basically to deal with unsanitary houses of all classes of the community and for conferring power on city, town, and village municipalities whereby they may not only control, but in a measure, direct town and suburban planning. So this was the direct call, actually, that led to town and urban planning in Canada, which happened around that same period. Charles Hodgetts contacted, as his role in the advisor to the Commission of Conservation for Canada, Thomas Adams, who is a pretty famous town planner who's Scottish. Here's a picture of him. I'm sorry I don't have a picture of Charles Hodgetts. I swear I looked everywhere and you can only find a picture of his grave. More impressively, he lived to be 92 at this point in history, which is really, really impressive. So Thomas Adams comes to Canada and brings town planning as a means of kind of separating out and dealing with some of these public health crises that are happening in cities. This is the original article from when Thomas Adams came to Victoria from the Daily Colonist, and it talks about his vision for city planning across Canada in 1913. But slowly over that next century, public health and urban planning kind of diverged. Public health became very focused on single agent causes of specific diseases. So rather than thinking about whole environments or whole social determinants, just getting very, very focused on like, if I can just figure out this one disease, the one etiology of this one disease, then I can stop that without thinking about the social context. And transportation became really invested in this thing you guys might have heard about. It's called a car. Yeah? Everyone? Yeah. This is a really interesting photo. It's from the World's Fair in the 1930s in the US. And you can watch this whole video on YouTube. It's the Futurama exhibit, or the Land of the Future, and it shows like what cities could be like. And it's basically like no walking, no biking, no engagement. You just should be in your cars on superhighways away from each other. So pretty fascinating. I would say that there are three main factors that I view as reconnecting these fields. And I would say that they kind of follow a pretty close trajectory to this engram. Obviously, for those of you who know engrams, this is not like this is just a plot of how often these words appear in Google Books. So it's just like a very, very rough test to see what's going on. And the first would be the obesity epidemic. The second would be a refocus on social determinants and epidemiology. And then the third would be the arrival of different tools and technology to really assess the geographic patterning in the first and the second of those. So the obesity epidemic that many of you might know about, you're maybe more used to seeing, or maybe I'm just more used to seeing the maps of this of the US, where you can watch it change over time, but is also very prominent across Canada. And food and physical activity, environments that might be beneficial to helping someone live a healthy life and maintain a healthy weight are things that started to come into the forefront of environments. Similarly, there started to be a focus on social inequalities again. And so these are your life expectancy at birth by sex and neighborhood income quintile. So the fifth quintile is the highest quintile, and the first is the lowest quintile. And we can see that the disparities in males is about 5 years, and for females is about 3-ish years. I will say this is across all of Canada. It's not within a city, but for comparison, within the city of Philadelphia, where I live, we have two neighborhoods less than a mile apart that have more than 20-year life expectancy difference. So geographic patterning of some of these social determinants is also very prominent. Which brings us to the GIS technology to actually start thinking about and really looking at with quite ease a lot of these issues. So this is neighborhood socioeconomic patterning. These are those 5 income quintiles for Vancouver local planning areas, median total income. And similarly, we can think about or look at neighborhood health patterning. So this is life expectancy for the community public health, I'm going to mess up the name, but the public health areas within Vancouver. So after that history, and these fields start coming back together, is my history and where I fit into this. And so this diagram, which I would love to take full credit for the setup, but I also will credit one of my close friends, Steve, who has conceptualized his paths this way as well. So you can think about, I was born, this is me as a little tiny baby, and I learned to walk, and that was my first form of transportation. And at that point, I lived in New York. These numbers next to each of these is the walk score of every location that I've lived at, or every major location I've lived at. I've actually lived at way more places than this, but all of my longer term locations, I grew up in an area that is not at all walkable, as you can see. Has a walk score of 0, an actual 0, 0, 0. Nothing. It's a very beautiful place for physical activity that is leisure-based, so not walking to get to different things. And I think became very interested in natural environments. So when I turned 16, I actually only got my license, my driving license, to study natural environments and geologic oceanography. And here's me on my 16th birthday, because I thought you guys might want that. I graduated, and you can see here that some of that emphasis translated between natural environments and their intersections with built environments, and simultaneously kind of expanded from obesity-related factors, so nutrition and physical activity, to more chronic diseases, and then equity has been a pretty persistent theme through my the end of my bachelor's, my master's, my PhD, my postdoc, and now. So my work, I usually like to think about it as connecting these large fundamental causes, so inequalities and macrosocial factors and those natural environments, to the health and well-being of populations. This is a diagram from Schultz and Northridge, and theirs has a lot more complexity, but to show you the portion that I fit in, built environments over here as an intermediate between these. And so one of the things that the field was struggling with is that we had very limited understanding of how neighborhood changes might precipitate health. So it's great if we think that more walkable places lead people to walk more, but if we don't actually know that that's the case, if we're measuring both of these at the same time, and it's possible that maybe more walkable people who like walking move to more walkable neighborhoods. Similarly, there's a residential selection effect that's possible, and this is even possible in longitudinal studies, but there's some temporal ambiguity, because maybe you live in a walkable neighborhood and that makes you walk more, or maybe you really like to walk and that's why you live in a walkable neighborhood, and both of those lead to you walking more. So some of my past work and my existing work tries to leverage longitudinal data to really examine changes in the built environment with changes in outcome. Here's a number of built environment measures that I've looked at for this particular cohort that I'll talk to you about. So they include walkability or population density, different land uses and land use patterns, access to different destinations, access to public transportation and street patterns, and then thinking about outcomes including walking, obesity, and uses a number of different multi-level longitudinal approaches, including a natural experiment type approach of using people who have moved, so residential relocation as a form of change, and trajectories. So the study that this data comes from is called MESA, the Multi-Ethnic Study of Atherosclerosis. It has 6,814 people who started at baseline at 45 to 84. They come from 6 different cities originally across the United States. This is Forsyth County, North Carolina, Baltimore, Maryland, New York, Chicago, Minneapolis, and Los Angeles, and they now live in almost all of the contiguous US states. And they've been followed, now they have a 6th exam, but what I'll show you goes through their 5th exam, so 12 years worth of data. So the first question we can ask to look at change is, what happens if someone moves to a new neighborhood? So you have these people and they live in one neighborhood, and they've moved to a new neighborhood. Does their behavior change, and do they have different health outcomes? So for this, we used a composite measure, walk score. Many of you are probably familiar with this, but it combines destinations with street characteristics and gives you a score from 0 to 100. This is the building that we are in right now on a sunnier day. And we have a walk score of 81. And then because they were the same people moving, we were able to leverage that large amount of change to do fixed effects models. So fixed effects models look only within the individual to estimate the regression coefficients. So what this does is it eliminates all between person variation. So you don't need to control for anything that's time stable. But it can't estimate coefficients for these time invariant predictors. So if you wanted to know gender, you would have to do an interaction. If anyone loves equations, this is the equation for you. If anyone loves people, this is Paul Allison. He designed this model. And if anyone is really wondering what's different about this model than anything else, it's that little That's okay. I do not mind at all. I'll just attach to it in a very complex way. It's okay. Yeah, this is great. Extra weight to carry around. I just talked about weight training. Lovely. And then their BMI actually also decreased. This is a very small BMI decrease, certainly for an individual, but for a population might have a big impact. The implications of this are pretty interesting. Moving to a location with better street connectivity and higher access to walking destinations can increase walking levels and decrease obesity. But the practical applications of this are a little bit challenging. Like, what are you really going to do? You're going to take everybody and move them to New York? Are you going to take everybody and move them downtown Vancouver? It's not really, I mean, that also doesn't even consider differential opportunities to move. So the second thing that we looked at was what happens if someone's neighborhood changes around them. So you stay in the same spot, and then your neighborhood changes around you. It either becomes more. Does that equal more walking? So for this, these are a bunch of GIS-based measures at 1 mile, buffers around people's homes. So we have population density, 2 measures of land use, a measure of social destinations and walking destinations. Sorry, almost. Anyone who's online can't see any of this. It's okay. Distance to public transportation, and we did buses because many of the other cities don't have trains. And then street patterns. So this is a network ratio, so how connected the streets are. So this model is a little bit more complicated, so I'm going to give you a visual because I'm a visual person, but I promise that it also has the equation at the bottom if you're an equation person. So the way that this model works is you have the walking level for an individual, and that's at baseline, that's the B0, that's the intercept. They also then have a time trajectory. This is how their walking changes over time. The reason I made this slightly positive is that actually we found in our cohort walking slightly increased over time among the cohort, partially probably because as people age, they replace walking behavior, they replace more strenuous behavior with walking behavior. Then you have the impact of your baseline built environment on your baseline level. So maybe you live in a more walkable neighborhood, and so that means you start off walking more. So that's where you start there. And then has an interaction term between this baseline built environment and that time slope. So this is saying, okay, you had one trajectory, now you're that trajectory plus a little extra. And then the change part is the difference from baseline in that built environment measure times that time slope. So I know that sounds a little bit confusing, but you're basically talking about the extra amount on that time slope. That's what the effect will be. And these are multi-level models that control for clustering by individual and by census tract, even though the measures are in buffers around people's homes. So what we see here, and the white or clear dots represent the baseline, is that lots of things at baseline are associated with the trajectory. So if you have more population density, higher percentage of land zoned for retail, more destinations, and a bigger street, a more connected street, your trajectory is more positive. With change, oh, and then with things that should be reverse coded, those are also negative. So baseline, we often see that. With change, what really comes through is that destinations and street network, the change in those is really what's associated with the change in walking over time. And again, this is for transport walking rather than transport and leisure walking. So creating more walkable neighborhoods may help increase walking and reduce obesity. And I would say that both in the movement literature and in this literature that I just showed you, destinations and density are particularly important influences, and that kind of confirms both the methodology behind walk score and some of the things that you're used to, and the residential relocation research. So if someone's neighborhood changes, we generally think there's more walking. I've done similar work to this in a lot of other cohorts and have a lot of experience linking this type of neighborhood data or creating these GIS-based measures for a large group of cohorts. They're listed here, and I'm not going to read them to you. But at present, I work on a really large data set of all of the US businesses between 1990 and 2014. It's 74 million businesses, classifying and coding them so that we can link them with US Census and mortality data, but also locally with Philadelphia data, and then with all of these cohort studies. So that's where a bulk of my previous research was, and so now I'm going to talk to you a little bit about what I currently do. And so this is that same model I showed you before, and what I would say is that right now I've expanded out into some more of those domains and thinking about that larger process more holistically. So I like to summarize my research as being driven by the desire to investigate multiple pathways through which population neighborhood health disparities arise. And the way that that's operationalized for me at present is through two main things. One of them is the multiple pathways, has to do with a more holistic view of health and a holistic view of environments. And then the second, which is the neighborhood health disparities, has to do with this dynamic interplay between health, neighborhoods, and populations. So first, let's talk about this holistic view of health. So competing pathways are probably, I think, not something new for you. That you have a lot of researchers in your division who think about these issues, but we could think about, let's say, dense urban planning leading to cardiovascular disease, and maybe dense urban planning leads to more stores, makes transit more efficient, there's more physical activity, maybe better food access, better nutrition, and those all lead to better cardiovascular health. But maybe at the same time, that dense urban planning means that that person has less green space, so they have less physical activity. Maybe they have worse mental health because of the green space or because of the less physical activity. Maybe they have more noise because of the stores, the extra stores, or the more people. Maybe there's more pollution. They have worse sleep. It's a lot. It's a very complicated. This is not a complete diagram in any way, shape, or form. This is just to illustrate that these pathways can be really complex when we try to think about cardiovascular health as a concrete outcome, and that's just cardiovascular health. That's not a whole host of other outcomes. So I've done a little bit of work at kind of trying to get at these other health outcomes. I have a paper that looks at built environment associated with depressive symptoms. So interestingly, and I will caveat this before I go into this very quickly, which is that places in our sample that have higher population density have higher depressive symptoms. So more people, like more dense places, more cities have more depressive symptoms. These models control for population density. So this kind of gets at, if you live in a dense place, so we know that lots of cities, lots of urbanization. So really, if you already live in a dense place, what features help with depressive symptoms? And we see that having more social engagement destinations leads to lower depressive symptoms. This is the CESD is a survey measure of depressive symptoms. It's not depression clinically. It's a survey measure, and this was just for females, and that's a cross-sectional association. Safety. So this is both self-reported and neighborhood-reported safety. So we have a bunch of people in the same neighborhood who report on the safety, who then inform the individuals. If you have more safety, you are lower depressive symptoms, and this is both cross-sectional and longitudinal, and then having more social cohesion in your neighborhood is associated with lower depressive symptoms. Similarly, I've done a little bit of work on sleep. Sleep is really complicated in this picture because there's noise, there's pollution, there's physical activity, there's depression. So all of those things factor into sleep, and sleep is very complicated, and I do not purport to be a sleep researcher, but I do purport to be a neighborhood researcher, and I will tell you that living in a more walkable place, including both a composite measure of walkability, so walk score, and the destinations or population density are all associated with less average sleep time. Yes. It's not actually that surprising because there's possibly more light. There's a lot, I mean, there are a lot of pathways by which that might work. I will say, and this is a big caveat and it's not in the paper, and it's unfortunate because of the study design that we can't really say a ton about this, but the effect of this is very strong in our Black and Hispanic participants and is almost non-existent in our white and Chinese participants, so that this study only has those 4 race ethnic categories. The patterning of race and space in the US makes it makes it impossible for us to tease those apart. So that's a complicated story. But this is, yeah, I'm happy to send you the paper. I don't know why it's not cited on the bottom of that. I'm sorry about that. So the implications of this is that, if we're building built environments that are going to be in place for 50, 100 years, as we did in the early 1920s, like you saw, then we have to be thinking about these long-term impacts of built environment changes. And there could be competing risks. So this man who's bicycling, maybe he's getting more physical activity, but he also maybe has more pollution exposure. Maybe he has more traffic injury risk. Maybe he has more stress from biking. Maybe he has less stress from biking. Who knows? And there's complex systems there to be thought about. And future work really needs to explore other health outcomes. In addition to this, I would, as someone who focuses on older populations, I would say that physical and cognitive functioning and quality of life are also really important. The second thing has to do with that spatial patterning and that dynamic between neighborhoods and populations. So I wanted to know what neighborhoods are changing, which neighborhoods get those positive amenities that we just saw were associated with better health. So I have 2 different studies that both collectively look at land use, destinations, bicycle lanes, off-road trails, bus routes, and parks, and kind of where those changes are happening. And what we find is that health promoting changes are more likely to occur in neighborhoods that are white and affluent. This is in the US, white and affluent at the beginning, and neighborhoods that experience change in these positive built environment amenities and features also experience increases in percent non-Hispanic white and increases in median household income. And this can potentially worsen health disparities. I would also then say that cities often try to do the right thing. So you have low-income areas that have low access, and some cities then try to prioritize equity and put new infrastructure in places that have low income and low access. But then that story can be really complex, and gentrification and displacement is definitely part of that, and then the subsequent changes in the population that occur with the environmental changes can't be overlooked. And then again, people get pushed out into worse built environments. So this relationship, and this is again not a complete diagram, this relationship is really, really complex when we start thinking about, well, what about gentrification specifically to health? And so some of my work has started to conceptualize that and think about that. These are some of the things that gentrification could impact, both positive and negative. I'm not sure why this T moved to the bottom, but displacement is part of that. There are positive things. Maybe there'll be more healthy food options or more objectively healthy food options, even if they're not socially or culturally appropriate. Maybe there's some better infrastructure for transportation or more trails or paths. And then lots and lots of potential health outcomes from all of these things, including some of the negative ones, so the stress of displacement or the financial stress of displacement. And ultimately, health outcomes. This is, again, just like to show you this is a very complicated picture. This is not meant to be a clarifying diagram, more a complex one. Further, we do see that often when we build new amenities in neighborhoods, the associations often differ within populations. And this can be within low-income individuals, minority individuals, or older adults, or any other marginalized group or group that might have other needs. So right now I have a project that's on equity and free-floating bike share. I bring this up only because I want to talk to you about different types of equity. So this is free-floating bike share are the bikes that you have here on campus, the drop bike. They're bikes that don't have to go into docks. And so one way we can think about equity is where are the bikes landing? Where do they end up? What neighborhoods are they in? And I would call that spatial equity. So this map on the left shows you the bikes available per day per resident. And the one on the right is just proportion of residents with a college degree. So it's just education. So we did an analysis that looked at 93 different neighborhoods across Seattle. We are hopeful in the next week or so that we might get the bike level data. It's very complex system, and I'm happy to talk to people about that. But at the same time, we also did a resident survey. And in the resident survey, this is of people whether they use bikes or don't use bikes. While 33% of Seattle individuals who answered the survey used bikes, they actually mentioned different barriers for their use of the bike. So Hispanic and African American respondents were more likely to agree that the barriers they were experiencing were geographic access or cost. And males were more likely to agree that the bicycle size, the maintenance, the cost, or environmental barriers were bigger issues for them. And then there were no differences in barriers by age. I will say there are not as many older adults using the dockless bike shares I would like, but so that might be part of that. And so this is a model, again, do not expect you to be able to see all of these tiny details, but this is a model that takes the socio-ecologic framework and really thinks about how that plays in when we're talking about a minority or any other disadvantaged group. And really thinking about the socio-cultural influences at the individual level, the structural influences, including political power and intergroup relations, the type of status, whether it's a new group, a new marginal group, or a long-standing historic group, and then obviously at the largest level, at the population level, kind of these historic experiences. So the takeaway from this, I would say, is that social equity is not spatial equity. So just having things in a set place is not the same as equity, right? There's social acceptability. There's financial factors that go into it, whether you can afford to use an amenity, and there's knowledge factors. Maybe you don't even know that that's an amenity that's for the public. And so it's possible, and I think likely, that multi-level interventions need to be designed that help engage people and communities and make changes in the built environment all simultaneously. So on to my future work before I leave you guys for questions. I would say there are 5 major trends that I see in this sphere, and my work taps into some of them. So the first are global trends that are happening. So lots of urbanization is happening all over the world. I don't at present do any global work, but I would say that these issues are becoming increasingly important and have a lot of prominence in many different settings. Similarly, here are aging. Here are the percentage of these areas that are expected to be over 60 by 2050, and we can see that this is a tremendous difference in designing our environments to be places that people can live, age, and stay in for their entire life course is very important. And then the third thing that's not on here, that's a big global trend, obviously, is sustainability and climate change, which obviously also needs to get incorporated into our design of cities and health. Another thing that I think we're going to see more of in the field and that my work continues to push towards is this kind of holistic health idea. We've got some air pollution. I would love to do some work with a lot of the researchers here who do air pollution work, noise. There's stuff around temperature changes, so heat effects of urban spaces. We also have the potential to think about mobility and physical functioning and cognitive functioning. We just received a grant on Alzheimer's disease and related dementia and its interaction with built environments for people's ability to stay in their homes. The third, again, is the equity piece, and I think that this is gonna, this is not my photo. You can go to Flickr, and I don't actually know what city this came from. I'll have to look into that, but I could easily see this in Philadelphia, and I think maybe also in Vancouver. Paying close attention to all of the different aspects that influence health, housing, and affordability, and built environments, and equity are all intrinsically linked. And I think that our ability to address those problems is going to also have to require a multidisciplinary approach and a solution that is tackled on a number of different fronts. Here in Vancouver, one of the things that I'm particularly interested in is as it unfolds would be the viaduct down on the downtown east side. I think might have interesting implications for some of these topics. Again, as I mentioned very briefly, I think multi-level interventions are needed that really get at individual barriers to, let's say, physical activity or to healthy aging, but also then get at community and at physical changes. So this is an image of the East Coast Greenway over here. It is a proposed, I'm putting in a big capital P in case any of you were like, oh, I'm going to go bike the East Coast of the US. Only a third of this is done, and it's in very tiny chunks. But they are making great progress. Started in the 1990s. One of the portions is this really critical bridge in Philadelphia. This is the old bridge that actually was just torn down 3 weeks ago. And they're building a new pedestrian and bicycle bridge. It will be the first pedestrian and bicycle only bridge across the Schuylkill River, which is our main bisecting river in Philadelphia. And it connects a very white, very wealthy center city with a very poor, very black Southwest Philadelphia. And there are a lot of historic, I think, tensions that go into the trail and into the space that have to be dealt with without this idea of just we're going to build it and suddenly the trail is going to have equitable users and that everyone in the neighborhood is going to be healthier and more active. So I'm working with some people from the Council on Black Health to design an engagement with a randomized controlled trial that engages individuals near the trail while also engaging communities and at the same time that the new trail goes in. And finally, I think as much as maybe we all hope that our technology disappears when it's like binging at us late at night, I think technology is here to stay, and I think thinking about ways that it integrates with new cities, so whether that's smart cities or dumb smart cities, or whichever way we want to think about this. This is a Strava heat map of Vancouver, and a lot of cities have started to use this type of crowdsourced data, and what does that really mean from a public health and a population health lens? What is the bias that's in that? What is the spatial bias that might be in that? And how are our decisions being made based on some of these technologies, or what can we gather from that? So both leveraging it for research, but also thinking about practice. And with that, I will leave you with my favorite quote that I always tell everybody, which is that the best time to plant a tree was 20 years ago, and the second best time is now. And with built environments, I would say that this is more true than in many, many other things that we do. So if you didn't start exercising yesterday, it's okay. But when we build spaces that will be around for a really long time, we maybe haven't gotten it perfect in the past. We probably won't get it perfect today, but we have to keep trying every day to start to get it right. And with that, I would love to thank, this is just a tiny snapshot. These are just my co-authors. There are tons of people who support me, particularly administrators who support me that are not written on here. And then there's obviously people who pay for all this, so they're on the bottom as well. And I would love any questions. I think you might need this.
We're going to share this as much as possible. So thank you very much, and also for leaving a good amount of time for questions, which is nice. Yeah. So we are open for questions from the audience, and we might have a few online as well, which we'll share. I'm going to start the ball rolling. I think you started your talk with the history lesson that really kind of, I guess, made the point that public health and urban planning were once tied together and have kind of split. And I see from a research perspective that those things have come back together, but I'm interested in your take on whether you think that's actually happening now. It's really starting to happen in practice. I know the research is there, but
yeah, I would say, and I can mostly speak to a US context, not necessarily to a Canadian context. In the US, I would say it's very regional and geographically patterned. So some of our major cities have had really strong reconnections of the two. New York City has many, many people who work between the public health department and urban planning. Even in Philadelphia, we're a smaller city. We are one of the 6 biggest cities in the US, but we're a smaller city, and those groups talk really, really actively. I'm part of the Delaware Valley Regional Planning Commission's Healthy Community Task Force, very long name, but basically it means it's a bunch of engineers, transportation planners, public health practitioners, and academics from both of those fields. And we all meet quarterly, which is maybe not very, very frequently, but to discuss relevant topics on different themes in all of these areas. San Francisco, I would say, has also done a really good job of integrating the two. So there's been select places, and as with many types of collaborations, I would say it's often due to really strong people and the will and political will. I have been in other parts of the US that I would say are, that will is not there, and nor is there really sometimes the acknowledgement of some of the factors that go into linking these fields back together, particularly social determinants. So in places where that is less acknowledged, I think that they are still far away. There are some changes that we see. You can track it actually. We do have a study that looks at complete streets policies. And so we can look at different urban planning policies and see if health is starting to be incorporated in a more meaningful way than just a mention. Who wants this microphone? Do a little ding.
Great, thanks for the great talk. The gentrification question is huge, and in Vancouver it's very big too, especially with the expansion of the downtown and going into Chinatown and downtown East Side. Have you seen any cities, or do you have any examples that have tried to tackle that in a equitable kind of way?
This is the $1 million question, or the hopefully the $100,000 question. It takes a very multi-pronged approach in Philadelphia. I'll speak to Philadelphia because I think that maybe helps, and we have a lot of issues with this, and I in no way am saying that Philadelphia has found a solution. One of the multi-pronged approach that they have taken includes housing assistance, so maintenance assistance for homeowners or for renters to ensure that people are not getting evicted from their houses by, real estate speculators who want their land, tangled title help, a land bank. So Philadelphia has a land bank now, so that properties that are in areas that, let's say, used to be really low income, that were all vacant and abandoned, went into this land bank, and now different community organizations can purchase them, or they get saved for different uses. So it's a pretty interesting strategy. They just implemented I gotta be really careful on my language. We have undergone 6 months of debates in City Council around a construction impact tax. So what this would do is that any new construction has an additional tax that has to go into affordable housing, above and beyond the affordable housing requirements of that development. It's a multi-pronged approach. I think nobody has a good answer, and certainly in situations, this is also true, there's displacement where someone is pushed out of their home, which is definitely the worst, but there is also displacement of long-term residents who choose to leave because the land has become so valuable that it's just worth it for them to sell, and then that breaks up communities, and then maybe someone else leaves that community because they don't feel welcome there anymore because all of their friends and neighbors and social group have left. So it is very complicated. I wish if I had the answer, I might not be a professor, I'd probably be a city council member. Yeah, I don't know if that helps a little bit. Yeah. San Francisco has a bunch more as well because they have out of control housing demands as well. I was at an interesting seminar 2 weeks ago that actually talks about cultural ways to combat gentrification. So kind of investment, really strong investment in arts and culture to keep the social structure strong enough that then there can be collective bargaining against some of these real estate companies and developers. But I think there are also, there's, in the US, there's a group of developers who have an organization called Locus, which I'm not going to remember what they stand for. They're actually about developing urban neighborhoods, and they started back when back with this idea of creating healthy spaces. But I think they've also tried to think about from their perspective. I think we have to bring those people into the conversation, because otherwise it's not going to happen.
Hi. I was impressed with your introduction and your knowledge of Canada, or your focus on Canada. How often have you visited Canada or worked here?
When I gave you the example of the 10-unit walk score, I gave you where we are right now, and then I gave you my office that I worked at down at VGH. I have visited for the past 5 years now with the Center for Hip Health and Mobility, and that group is across both UBC and Simon Fraser, and I've done lots of different projects. I mainly just love them, and they're amazing, and so I've come up as often as I can. I am not Canadian. I did have quite a lot of fun looking through all your old newspapers for what I actually have an analogous version of that history for the U.S. that I've known for quite a while. Really interesting fun fact for you, trivia. Thomas Adams, who's the founder of the Canadian Planning Institute, which became the Canadian Association of Planning, or whatever the acronym is also the founder of the American Planning Association. So this Scottish dude, basically, he came and just did. Yeah, and then we don't have any pictures or any real records of Charles Hodgetts, this actual really hardcore public health guy who drove this whole movement in my mind and brought Thomas Adams from Scotland. But that article from the Daily Colonist is really fascinating. I did find some other very interesting news from across the provinces when I was digging through the archive. You'd be really surprised. I highly encourage anyone who needs a study break from this part of the room to get lost in the Google News archives, or anyone from the US who's maybe listening who's struggling with the current news. I would suggest the old-time news includes some really, really key gems. So, no problem. Maybe I should have left it. Yeah.
Great, thanks. I've got a question really about how you visualize or conceptualize using your research findings to actually affect change, because you're really talking about improving health and health equity at the level of the neighborhood, and as you talked yesterday, that's really constructed in a very complex way, where you've got points of intervention at the level of the community all the way up to the federal government. So you talk maybe a little bit about how you see yourself working in terms of informing change, and maybe some examples of how you've done that previously.
So I think I'll use the bike share study because it's a very easy example, which is not to say that bike share is like any other type of built environment. The city of Philadelphia is undergoing and trying to understand whether they're going to implement dockless bike share or free floating, whatever we want to call it, in addition to their existing. And so as part, I am connected with the Office on Transportation Infrastructure Systems, OTIS, our Department of Transportation, and I work with them quite closely to understand what are your concerns when it comes to equity? What are we thinking about? What types of questions, what types of answers can I help you sort through to understand how to make your decision? So I don't think it's my role to actually make any of those decisions for, government officials can and should do what is within their expertise. And my role then is to understand it and kind of give that support. So, they were saying, well, we're really worried about rights of way because these bikes get parked all over. And what do we know about that in Seattle? And what different equity measures have been included in previous, they're not always permitting. Looking at Kate, because we just went through this for a large paper on free-floating bike share. They're not always permitting legislation, but let's just call it permitting legislation. legislation. So what types of equity measures are in these permitting legislation? And so I was able to go and kind of sift through and figure out, and like Chicago, this is obviously with the help of the North American Bike Share Association also does a lot of this, but come to the city of Philadelphia and say, well, Chicago puts in hiring practice requirements for these companies and puts in public meetings that you have to have with these companies, that the companies have to have with communities, and puts in a certain number of the fleet has to be in these types of neighborhoods, or if you put a certain number of bikes in these neighborhoods, you get an extra bump in how many bikes you can have on the road, right? So you give someone the options and understand where they're coming from and what those concerns are and how that connects with my work and the equity work to then help them make those decisions. No problem. I think there are people online. You have to,
So I'm, as you know, we're part of the Faculty of Environmental and Occupational Hygiene, and most of the students here are focusing on occupational hygiene. So I was wondering, as a potential professor of ours, how do you think that your research could apply to occupational hygiene?
So I think that a lot of my social determinants work is directly linked and is something that's very easy. But if we wanted to think more specifically, when we think about the structures of different neighborhoods and patterns, all of that, especially like equity, factors into where different economies end up and where different commuting, like where people can and will commute from, and what jobs actually are available to them. So there's the even the first part of like really what jobs they might end up in. Occupationally, I mean, we spend much of our time at work, and there's one thing about understanding residential environments, but understanding work environments and understanding the way that those might shape health behavior or emotional health or physical health is part of that. For aging, I think that one area that's particularly interesting is people's changes in patterns and environments as they transition to retirement. I think it's particularly interesting. I don't know that it's what occupational students are interested in. It's the exit from occupation, but I think on the aging side, that's something that's particularly interesting. I think also for aging and equity, we have whole issues of like what the workforce will be like to actually accommodate some of these, and where is that workforce located geographically and spatially. And so a lot of these methods, maybe my content is not as occupational health, let's say, but the methods and the concepts are always translatable and are able to be applied more broadly.
So just as a reminder to all of those online as well as in the room, there is an opportunity to provide us with feedback on the seminar. So I point you here to the evaluation form. Even if you just Google SPPH OEH seminars, you find Dr. Hirsch's seminar, you will find the link for the evaluation form. So it is an opportunity for you to provide us with feedback, and we would welcome that very much from those of you who might have this individual as an instructor in the future or as a colleague. So we would welcome that feedback. At this point, I'd like you to join me in thanking Dr. Hirsch for her presentation this afternoon. Thank you.